We will be mainly focusing on migraine, tension type of headache. We will also learn about a common approach to a patient with headache, including red flags or worrisome signs. So, as we already discussed, in general population, around 6% patient will have secondary headache and remaining patient would have migraine. Out of all the headaches, 76% people will have migraine, 3% people will have tension type of headache, and 3% people will have other headaches. International Headache Society had classified headaches into 3 types. Type 1 is primary headache, type 2 is secondary headache, type 3 is neuralgias. So primary headaches are the headaches where we do not find any pathology or space occupying lesion or any abnormality with structures in and around head and neck. Okay, so these headaches occur without any primary pathology. So there are mainly 3 headaches which are included under this category. First is migraine, tension type of headache, and cluster headache. And out of these 3, migraine is the most common primary headache. The second category is secondary headache. Secondary headaches are the headaches which occur because of some problems with the structure in and around head and neck. Okay, so it can be attributed to either head and neck trauma, vascular disorders including cranial and cervical vessels, which may include stroke, either thrombotic or hemorrhagic, non-vascular intracranial disorders including intracranial space occupying lesions like tumor or again infections, abscess, headache because of substance abuse or its withdrawal. Example is cocaine and alcohol. Whenever patient takes a lot of alcohol, they will develop headache, which we commonly know as hangover headache, which occurs in the next day morning. Sometimes withdrawal of the alcohol will also cause headache. Headache attributed to infection, including meningitis and encephalitis, intracerebral abscess, tuberculosis. Headache attributed to disorders related to cranium, eyes, nose, ears, sinuses, teeth, mouth, and other structures. Examples are sinusitis, rhinitis, nasal polyps, middle ear infections, otitis media, otitis interna, otitis externa, maxillary sinusitis, refractory errors, most common headache which occurs in young people. Then a glaucoma, in which intraocular pressure increases and there will be redness, watering, and headache. Okay. Then periapical abscess, odontitis, pyorrhea, gingivitis, and sometimes herpes zoster infection involving ophthalmic division of trigeminal nerve. It can also cause headache. So you see, all the headaches in such category are because of some other factors. And if we treat the primary etiological factor, headache will disappear. Okay, headache because of psychiatric disorders like depression. So you need to treat depression and headache will disappear. Just giving a non-steroidal anti-inflammatory drugs or painkillers will not help in this category of headache. And if you miss, patient may get critical, patient may even die. Neuralgias are most common. In amongst those, trigeminal neuralgia and glossopharyngeal neuralgia are most common. The famous actor Salman Khan suffers from trigeminal neuralgia. So whenever we approach to a patient with headache, when we take history and when we do examination, our first aim or first motive is to look for any secondary cause, because we have seen the list. So if you miss any secondary headache, patient may die. There is a risk of death. That's why we should always try to look for secondary possible headache. For that, there are few risk factors or red flags are identified. If headache occurs in such scenarios, we should always admit these patients and we should investigate further. So these scenarios are known as red flags. સામાંથી કંઈ પણ આવે તો તમારા બ્રેઇનમાં એક આઈડિયા આવવો જોઈએ કે this patients should be admitted. Okay. What are those red flags? So red flags are known as worrisome headaches. We have formed a mnemonic for that to remember it easily. SNOOP. SNOOP means SNOOP. In that S, when headache occurs with systemic symptoms like fever or weight loss, okay, this patient may have either tuberculosis or malignancy or HIV. So such patient should be investigated. If you miss tuberculosis, if you miss HIV, patient may die later on. Headache occurs in patient who is known to have HIV or who is known to have malignancy, because these both patients can have intracranial metastasis or intracranial lymphomas or opportunistic infections. Headache with abnormal neurological symptoms and signs, like headache with altersensorium, headache with seizure, headache with confusion, or headache with coma. These patients might have intracranial tumor, infection, or stroke. Just giving non-painkillers would not help him. Headache which has sudden abrupt onset or headache occurs in seconds. 5 મિનિટ પહેલા તો પેશન્ટ એકદમ સ્ટેબલ હતા, અચાનક જોરથી માથું દુખે, which is unbearable. This would be a classical history of subarachnoid hemorrhage. Okay, bleeding occurring into the subarachnoid space. You all know it's a narrow space. So if you don't treat in time, some patient may have aneurysmal bleed, intracranial aneurysmal bleed, which may lead to subarachnoid bleed. So if you don't treat in time, the bleeding may increase. It will lead to intracranial pressure increase, and ultimately the respiratory centers and blood pressure maintaining system centers would be suppressed and patient may develop cardiac arrest. So headache occurring suddenly, it's a red flag. New onset of progressive headache, especially in elderly patient. ઘણા પેશન્ટ એવા આવે કે મને સાહેબ 50 વર્ષની ઉંમર થઈ ત્યાં સુધી તો માથું દુખતું જ નહીં હતું, પણ હવે અચાનક headache ચાલુ થયું છે અને it is not stopping. You should think that it's a worrisome sign. Okay? A disorder called giant cell arteritis, where inflammation of medium-sized arteries would occur. Okay, like temporal arteritis, retinal arteritis. These patients would be around 50 years, most commonly females. They will have temporal pain. Along with that, inflammation of arteries, raise ESR. If you diagnose it, we can diagnose with the help of arterial wall biopsy. It's very easy to treat. They respond to prednisolone. It's a steroid drug. Okay, and patient would be cured. But if you miss the diagnosis, patient may become blind because of inflammation of retinal artery. So headache first time occurring in elderly, it's a red flag. When patient has past history of headache and the history is progressive, okay, increasing in severity, મને સાહેબ પહેલા માથું દુખતું હતું પણ મહિનામાં એક જ વાર દુખતું હતું, પણ હવે અઠવાડિયામાં એક વાર અથવા તો રોજ દુખે છે, પહેલા કરતા સિવિયારિટી પણ વધી છે. So change in frequency, change in characteristic, change in severity, change in duration. You should think that patient might have developed some secondary cause. Okay, so systemic symptoms, headache in cancer and HIV patients, headache with altersensorium seizure, sudden onset of headache, headache in elderly patient, and change in the characteristic of previous headache. You should admit the patient. You should do imaging and further investigations to look for the secondary cause. So if you go to previous slide, so when we take history, first look for the red flags that we already discussed. If there are no red flags, then most likely the headache is primary, like migraine, tension type of headache, or cluster headache. You should treat according to the diagnostic criteria. If any red flag, then most probably it is secondary headache. You need to go for the imaging, CSF, and further testing. Now we move on to most common headaches, that is migraine versus tension type of headache. Why I have taken both the headaches in single slide? Because both of them are very common and both of them are difficult to diagnose. So if you understand the diagnostic criteria, then it will be very easy for you to diagnose. Okay, so migraine. I hope, I know that many of you in your class would have migrainous headache. Okay, so those who have history of migraine, they would understand that how do we diagnose? It is easy for them to understand. So in migraine diagnostic criteria, patient should have more than or equal to 5 attacks of headache, usually last from 4 hours to 72 hours. So suppose some patient says that મને માથું દુખે છે અને 10 મિનિટમાં કે અડધો કલાકમાં મટી જાય છે, then it's not migraine. Okay, it may be tension type of headache but not migraine. For migraine it should be at least 4 hours to 3 days. So more than or, and that should be more than or equal to 5 episode of headache in the past. Then you can label that patient might have migraine. So along with 5 attacks, there should be more than or equal to 2 criteria of following 4. So headache may be unilateral, headache should be pulsatile, headache should be moderate to severe in intensity, and patient does not want to work. Headache usually would be aggravated by physical activities. So all 4 may not be needed, but at least 2 should be needed. That means headache in migraine may not always be unilateral. It can be bilateral also. Okay. So more than or equal to 5 attacks of 4 hours to 72 hours, unilateral, pulsatile, severe intensity, and aggravated by physical activity. More than or equal, along with that, headache should have more than or equal to one of the following. So either nausea and or vomiting. So nausea and vomiting both can be there. Photophobia means avoidance of light, and phonophobia means avoidance of voice. So migraine patients particularly do not like to work. They want to sleep in quiet, dark room. That's how they behave. In TTH, the duration of headache would be 30 minutes to sometimes 7 days. Okay. There should be such 10 attacks in past or more. Why it is called tension type? Usually tension type headache doesn't occur because of tension or stress. But whenever patient is having stress, he usually keep his hand on the forehead. So that is the area where TTH would occur. Band-like head pain over the forehead. Along with the 10 episodes, there should be more than or equal to 2 criteria. So in contrast to migraine, TTH tension type of headache would have bilateral headache. It would be non-pulsatile. It would be mild. Usually would not be aggravated by an activity. So patient can continue his work. There won't be any nausea, vomiting. There won't be any photophobia or phonophobia. So I hope now it's clear. How do we differentiate between these two? Migraine will have some triggering factors. So if patient would have these factors, patient would develop headache. So in other way, if just by changing lifestyle, just by simply avoiding these triggering factors, we can prevent future migraine episodes. Okay. So more physical activity, head trauma, fever, anxiety, stress, lack of sleep, then hot weather, diet containing cheese, pasta, pizza, fermented food, chocolates, and hormonal changes including premenstrual phase. Okay, these are the factors which can trigger migraine. When we are discussing these 2 headaches, you know, whenever we feel headache in India, painkillers are the drugs which are available over the counter. Means you can get it without any prescription. So there are many people in the society, they become fond of or habituated to take analgesics. Whenever they develop mild headache, they take analgesics, and ultimately they overuse it. So because of that, we are finding some patients who develop worsening of headache because of taking overuse of analgesics. Okay, and just by simply stopping the analgesic drugs, you can cure that headache. That is known as medication overuse headache. What is the diagnostic criteria? When patient takes analgesics for more than or equal to 10 days for at least more than or equal to 3 consecutive months. એટલે કે દિવસ દર 3 મહિનામાં at least 10 થી 15 વખત પેન કિલર લીધી હોય તો એને analgesic overuse કહેવાય. Headache should worsen during the overuse of drug, and when you stop the drug, headache should become normal or should revert to the previous pattern within 2 months. What are the drugs which can cause this headache? So ergotamine, triptan. These are the two drugs which two drugs which are used in migraine episodes. It's okay if you're not able to remember the names because you will be taught in the pharmacology in detail. Along with that, simple analgesics by Voveran, diclofenac, opioid analgesics like tramadol, or combination of the medication can cause headache. What are the risk factors? we have already discussed the overuse of analgesics, depression, sleep disturbance, hypertension, uncontrolled blood pressure, dietary triggers, type A personality, refractory errors. These are the causes of recurrent headaches or frequent headaches. So when we investigate, we need to take proper history and we need to check for the red flags. EEG. Well, now we will be discussing about diagnostic tools which can help us to reach to the diagnosis. So one is EEG. EEG is also known as electroencephalography. Usually EEG is not much helpful when we investigate any patient with headache. It usually helps when patient comes with history of convulsions. Imaging, CT scan and magnetic resonance imaging or MRI. CT scan will help us when we suspect hemorrhage, as we discussed, no? Headache occurring in split second. In those patients, CT scan will help us because hemorrhage would be better picked up in CT scan. But otherwise, rest of the other headaches, MRI, magnetic resonance imaging would help us in better way. There is a headache protocol which usually is run in the imaging center. Lumbar puncture. This is the process where we remove cerebrospinal fluid from the subarachnoid space in the gap between L3, L4 vertebra or L4, L5 vertebra, and we send the fluid for the diagnostic testing. CSF will help us in diagnosing two conditions. One is headache because of infection, secondary headache, meningitis or encephalitis. Second is subarachnoid bleed, where we can find some hemorrhage or RBCs in the CSF. So whenever we develop any acute attack of migraine, how do we treat? Those who are suffering might know. You can take non-steroidal anti-inflammatory drug. You can take domperidone because it will act as anti-emetic, and sometimes in severe headache, ergots. You will be taught in detail in second year in pharmacology. How do we treat migraine? So don't worry. So conclusions. So migraine is the most common headache disorder seen in ambulatory emergency practice. Systemic approach to the headache using diagnostic criteria and looking for the SNOOP or the red flags will help you to differentiate between primary and secondary headache. And it will help us to reach to the accurate diagnosis. CT brain can miss secondary causes. MRI would be the better modality, except subarachnoid hemorrhage in patient with SH. Now we will see some cases which will help you to understand. So when we had a 35-year-old female who had headache for 2 months duration, headache, two episodes in a month for per month for last 10 years. So more than 5 episodes. Okay. Headache usually increases with stress, fasting, and sleep disturbance. Usually unilateral, that is right temporal, mild for 1 hour, and then becomes throbbing for 24 hours. Continuous with nausea and vomiting, and ultimately after 24 hours, headache improves. Okay, so you can see here all the diagnostic criteria of migraine fits. More than or equal to 5 episodes, duration is more than 4 hours, associated with nausea, vomiting, pulsatile, unilateral in a young female. Okay, with the classical triggering factors including stress, sleep disturbance, and fasting. So this is primary headache without any red flag. This is migraine. Case 2, 35-year-old female, history of oral contraceptive pills, which is very commonly used in these females. Had history of headache for 3 days, first time in life, throbbing, unilateral, associated with nausea, vomiting, and photophobia. But there is history of double vision or diplopia. So you can see there is no past episodes of headache. Okay, though duration is more than 3 days, but it is for the first time in life. There is history of some drugs. Okay, and history of a focal neurological deficit in form of double vision. So this is not a primary headache. This is a secondary headache because there is a red flag. There is double vision. Okay, this patient had cranial venous sinus cerebral venous sinus thrombosis because of OC pills. And if you don't give heparin, their brain will become edematous and they can die. Okay, so this is a secondary headache. We should admit the patient, we should do MRI, and we should treat further. Case 3, 50-year-old male, hypertensive, first major headache, suddenly in 1 hour back, along with neck rigidity, and blood pressure is 160 by 100. Okay, so here many red flags. First time in life, so there is no past episodes of headache. Severe and sudden in split seconds for last 1 hour. More than 50 years of age, male and hypertensive with neck rigidity. So again, it's a red flag. So red flag of split second, more elderly, more than 50 years, neck rigidity, and first headache. This patient was admitted. We did his MRI and he was found to have subarachnoid hemorrhage. So this is not a primary headache, but it's a secondary headache. Case 4, 60-year-old male, history of progressive worsening headache for 4 weeks. Mild weakness in right upper limb, mild forgetfulness, one episode of confusion with some movement of the body parts, and then it improved. Okay, so this is also not a primary headache. You see headache occurring after 60 years. That is 1. Second, headache changing its characteristics over the period of 4 weeks. That is 2 red flag. Third red flag is headache with focal deficit. He had right upper limb weakness. Fourth red flag is forgetfulness. And fifth red flag is episode of confusion, which was a seizure. Okay, so this patient was also admitted. We have done his MRI and we found that there was some tumor in the brain, which was leading to such symptoms. So it's not primary headache, but it's a secondary headache with multiple red flags. Case 5, 30-year-old female, headache for 5 years. It is bilateral, frontal, progressively throbbing, now constant. Migraine on treatment, daily painkillers, PCM, ergots, multiple dosages. Also flunarizine, which is a drug used in the psychiatric conditions. So now we would have understand this is a medication overuse headache. Okay, she was known to have migraine for 5 years and she is frequently taking painkillers and her headache is worsening. It is becoming constant headache now. So we stopped the medications and patient improved in next 3 months. And this is the last case. Okay, 45-year-old male presented with history of headache for 3 weeks. It usually remains right temporal, throbbing. But here, patient also has history of right eye gets red, swollen, severe tearing, nasal secretions, lasts only for 30 minutes, then improves. Okay, similar episodes of 4 to 5 times in a day. When patient presented to our hospital, we have given some oxygen and then headache went. We prescribed indomethacin. It's a non-steroidal anti-inflammatory drug and patient was free of headache. Okay, so with this headache we have not discussed in our presentation. This is a classical history of cluster headache. Okay, you should think of glaucoma in such scenario, but only thing is glaucoma usually would not be episodic. Glaucoma means raised intraocular pressure. When such people come, they would have constant red eye, constant periocular pain, and continuous headache. It would not be episodic. Glaucoma patient would not improve with oxygen. They would not improve with non-steroidal anti-inflammatory drug. They would require some intraocular drops, timolol, which will improve the angle. Okay, so you should remember it's a classical patient with cluster headache. So I hope now we will remember that that whenever headache comes, you should differentiate between primary, secondary headache. You should look for the red flags, and whenever red flags, admit the patient, go for imaging and further management. Okay, this is a picture which depicts patient with migraine. You can see. Okay, patient doesn't want to hear sound. He wants to avoid sound. He closes eyes. Okay, he is vomiting. He is avoiding light. There are few foods like chocolates, soup, canned food, egg, okay, wine, pasta, pizza. It will lead to headache. Patient want to sleep in the dark room. He is avoiding noise. Okay. So this is a classical picture of migraine. I hope you would have understand the basic approach to a patient with migraine or patient with headache. Please do take care of yourself and stay safe. Goodbye.